Over to you, sir.
Good afternoon, doctors. Welcome to this webinar on rational approach to viral respiratory tract infection with Dr. Pramod Jog as moderator and Dr. Sanjay Nathu as speaker. This program is brought to you by Heathrow Healthcare, an innovative pharmaceutical company. Heathrow Healthcare, the journey began in 1993. Heathrow Healthcare has 30 years of excellence and 36 state-of-art manufacturing facilities, 300 plus products in portfolio and presence in 126 plus countries. Heathrow Healthcare has 21,000 employees globally and is the largest closely held pharmaceutical company in India. It is amongst the largest manufacturers of ARV, APIs, and FDFs in the world, and is Asia's largest API manufacturing facility at SEZ Complex, Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties, pioneering in quality and innovation, and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Heathrow Healthcare, the pioneers in antivirals, offered oseltamivir, favipiravir, and remdesivir to the patients, because of which, in August 2020, Heathrow Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, Rational Approach to Viral Respiratory Tract Infection. We have Dr. Pramod Jog and Dr. Sanjay Nathu with us. Dr. Pramod Jog is MD, MN, AMS, FIAPA, AFIC, MCH, PG Diploma in Pediatric Infectious Disease, Best Performer at ADVSC France 2011, MS Sanskrit and Proficiency in French and Spanish. This is great, sir. The Director, WOB 218, Professor of Pediatrics at DY Patil Medical College, Pune, National President, Indian Academy of Pediatrics, IIP 2016, Standing Committee Member, International Pediatric Association, Steering Committee Member, GAVI CSOSC, Standing Committee Member, ASPID, Consulting Pediatrician, Medipoint, Jupiter, Ankura, New Sanghavi, and Dinanath Hospitals, Senior Consultant to UNICEF, and Member, Maharashtra State Pediatric, COVID and Measles Task Force. Once again, a warm welcome, Dr. Pramod Jog.
Thank you.
Dr. Sanjay Nathu, sir, is MD, DNB Pediatrics. Sir is Professor and Head of the Department, SK Medical College, Pune, President, IIP Pune Branch 2021. Welcome, Dr. Sanjay Nathu. And with this brief introduction, I hand over the session to Dr. Pramod Jog. Over to you, sir.
Thank you. I will just start sharing
my
screen. Just 1 second. Okay. Just tell me whether it is visible.
Yes, sir.
Yeah. Okay. Thank you. So then we can start with, okay. So good afternoon, friends. Today we are going to discuss about the rational approach to viral respiratory infections. And all of us know that viral respiratory infections are the most common illnesses in children, accounting for the majority of the outpatient visits. And they also are responsible for emergency room consultations and even hospital admissions, particularly in children who are under the age of 5 years. And they contribute significantly to antibiotic overuse. What happens is, when a child is brought to the OPD, if a practicing pediatrician or a physician doesn't understand whether it is viral or bacterial, he feels, let us give antibiotics, what is wrong in giving, what happens? So he is not very much concerned about other aspects like, whether this will lead to antibiotic resistance, whether these antibiotics are necessary and so on. So these viral infections contribute significantly to the antibiotic overuse. Also, they are responsible for school absenteeism, parental anxiety, and cost to the pocket of the parents. Okay. And seasonal surges and the post-pandemic shifts have altered the patterns of presentation. And during the course of today's discussion, we will discuss about it. So, Dr. Nathu, I welcome you for this webinar. And I will just like to know what is your experience about the viral respiratory infections in your day-to-day pediatric practice.
Yes, sir. Good evening, sir, and good evening, everyone. So yes, thank you for the question. So we all know that viral respiratory infections are the big chunk in the pediatric practice today. In the last 2, 3, 4 months, we have been seeing a lot of patients coming with typical symptoms suggestive of a viral infection. And I would say they constitute more than 90% of our patients who visit our OPDs. with some illness tend to be viral respiratory infections. Gastro has gone down a lot with the vaccination, and hence viral respiratory infections form a big part of our daily pediatric practice.
Thank you. Now, the thing is that the era after COVID has changed the pediatric viral respiratory infections. So, what do you think as to how has it changed these, presentations of viral respiratory infections? What is your opinion?
So that is true, and all of us have observed that post-COVID, the proportion of viral infections which came to us has increased significantly. And there are several reasons which could be attributed to it. One of the important reasons could be the missed vaccinations during that time. The other would be that the children were completely isolated at their home. So they were not going to the school, not mixing with other kids. And as a result, they did not develop the typical exposure to various viruses which occurs in the growing age. And hence, they would not have developed a sufficient amount of immune response to those viral infections. So something like an immune debt may have developed in these kids, and which is now presenting in the last 3 4 years with increased number and sometimes a more severe presentation of our typical viral infections, which we did not see that frequently, say, in the pre-COVID era. So yes, post-COVID, definitely the number of viral infections has gone up for sure, and the presentations have also become more varied, sometimes more severe, and probably COVID is to blame for it indirectly.
Sure, sure. And I might add to what you said is that, there are some papers which say that the seasonality of some of the illnesses has altered. For example, we are getting off-season RSV, respiratory syncytial virus, off-season influenza, and the parental awareness and anxiety has also increased. Because after COVID, they were basically worried about COVID, and then now these viral infections, because as you said, there was no immunity during COVID, and that's why when the upsurge is being seen, parents are also worried. And I would also add to what you said that the use of diagnostics for diagnosing viral infections has also increased after COVID. I hope you agree with me. So, yeah, anyway, so with that, I would just put a case for your perusal, and that's a 6-year-old girl who attends the daycare, presents with rhinorrhea and a daytime cough for the last 8 days. She had fever for 2 days and appetite is poor. And on examination, there is clear rhinorrhea, and the remaining examination is unremarkable. So, obviously, it appears that this is a case of viral upper respiratory infection. And I would just like you to tell as to what are the viruses which most commonly cause respiratory infections in children.
Yeah, so this case which we saw is a common case which we have been seeing last several months, and most of our time in the OPD is spent dealing with these type of patients and their parents. So, lot many viruses are involved in causing different types of respiratory symptoms in children. The human rhinovirus, which we are aware of, is supposed to be a very mild virus which causes only mild upper respiratory infections. But occasionally, it may trigger a wheezing in a child who is susceptible, who is having a reactive airway, and occasionally is also associated with bronchiolitis. Coronavirus, we know one of the variant was the SARS-CoV-2, but otherwise, it is commonly associated with the common cold, and that is the presentation of coronaviruses. RSV, last 2 3 months, we had bad episodes of children presenting with bad bronchiolitis in young children less than 1 year or less than 2 years of age. So, notorious for causing bronchiolitis. HMPV, that is human metapneumoviruses, supposed to be a very innocuous virus, but does occasionally cause pneumonia and bronchiolitis. And if you look at the literature, it has been often shown to be associated with children who have a reactive airways. The asthma becomes apparent after an infection with human metapneumovirus, and this has been mentioned in the literature. Then we are all aware with the familiar influenza, that is influenza A and B mainly A actually. And again, last 2 3 months before say Diwali or so, we had a lot of patients coming up with influenza, and they had varied presentations. Some of them had severe infections as well. Parainfluenza, and they did develop, some of them did develop pneumonias. Parainfluenza viruses are also common, more associated with croup, that is a typical respiratory infection which involves the upper respiratory tract with a stridor, and adenovirus, which is commonly associated or commonly described to have a pharyngoconjunctival fever. That is, children present with conjunctivitis along with a sore throat and some fever, And these children often have a converse presentation on investigations that is they may have a higher count, the CRP may be higher, and the fever may also last a little longer. So that is characteristic of adenovirus. Hand foot mouth disease or its variant, that is herpangina, which affects only the throat. So the Coxsackie viruses, basically the enterovirus and the Coxsackie viruses are involved in herpangina. And as you were mentioning about the seasonality, even this herpangina and hand foot mouth is coming in unusual seasons this year. So these are the different viruses which we commonly deal with in our patients who come to our OPD with various respiratory signs and symptoms.
Sure. Now, maybe one can remember that the child, on an average, gets about 6 to 8 colds per year, and 10 to 15% of children get about 12 infections per year, and the incidence of the illness decreases with increasing age, and it goes down to 2 to 3 illnesses per year by adulthood. And children in the out-of-home daycare centers during the first year of life suffer from 50% more colds than children who are cared only at home.
So even
And
those,
yeah,
sorry to interrupt, even those with those 10 to 12 infections are commonly, if you take a history, they are going to daycare and catching various viruses from that place.
sure. And these are the ones who very often come to our OPD, and the parents are worried about those so-called back-to-back viral infections. And these children have a scratchy, sore throat, nasal obstruction, rhinorrhea, and they have cough, particularly in two-thirds of children. And the cold may last for about 1 to 2 weeks, and they may have fever and constitutional symptoms. Of course, the change in the color or the consistency of the secretions is common, and it does not indicate sinusitis or bacterial superinfection. One can encounter swollen erythematous nasal terminates. Dr. Sanjay, will you like to elaborate a bit about the treatment aspect of such a condition?
Sure, sir. So the treatment of the children who come with this typical viral infections is basically based on supportive care. There are hardly any medicines which are required. Of course, a lot of time needs to be spent with the parents to convince them that this is a simple viral infection, which is usually going to run its course, and you just need to give some symptomatic relief and a good supportive care. Sometimes the parents keep on insisting that whether an antibiotic is required or not, and it is our job, it is our duty to discuss with them that why and how the antibacterial therapy is going to be of no benefit in the treatment of some common upper respiratory infections like common cold. So you have to harp on adequate oral hydration, and that is something which we often forget. The parents often come with complaint of poor intake. So we have to tell them that the child's intake may be less because of the fever, but you have to ensure that if not solids, then a lot of liquids are regularly given, and small frequent feeds are to be given. Warm water, warm fluids are good. For nasal block, saline instillation regularly, even every 3 to 4 hourly, or saline irrigation in an older child may be useful. And we have to remember that these cough and cold products, which are commonly available in the pharmacies, are usually of no use for irritants. In fact, they are not supposed to be used in infants, especially in infants, and we have to avoid them as far as possible in children younger than 6 years of age, because most of them do not have what you can say permission to be used in children less than 6 years of age. So, to tell the truth, that hardly actually required also. So, we need to be confident that they are not required that much, and we need to counsel the parents accordingly. There's a what you can say tendency of writing first generation antihistamines. We have to understand that they may reduce rhinorrhea, but maybe only in 1/3 of patients, and that is because of their anticholinergic effect, which they may have along with their antihistaminic action. You have to remember that these first generation antihistaminics tend to cause a lot of sedation, and if at all you are going to use that, you have to counsel the parents accordingly. Pseudoephedrine, phenylephrine, maybe they have some little bit of a role to treat the nasal congestion, but in younger children, they are not at all required and not at all advisable. Oral adrenergic effects agents are less effective than topical. So maybe the topical sympathomimetics can be used for a short period, maybe a day or two only, maybe only occasionally, for a child who is severely troubled because of a blocked nose at night and not able to sleep. Maybe in addition to saline instillation, a dose of nasal adrenergic agents may be of some value. Vitamin C is always going to be helpful. Guaifenesin and all those stuff have mixed evidences. Warm humidified air, but we have to remember that they do have a placebo effect. They do help to keep the parents to occupied to some extent. They are not harmful and may have some placebo effect as well. So as you can see, it is basically a supportive treatment, hardly any medicines. Of course, you need to give paracetamol and only paracetamol for complaints of fever or body ache which the child may have. And that is the only actual medicine which you need to prescribe for the patients with these viral type of upper respiratory infections.
Sure. Now, could you just explain the course of an uncomplicated viral URI with the help of this graph?
Yes, sir. So this graph is very beautifully demonstrating how a typical uncomplicated viral upper respiratory infection would behave. So as you can see, the x-axis is showing the days and y-axis is showing the severity of the symptoms. The orange line is depicting fever. So you can see that the fever tends to be high and frequent in the first 2 or 3 days. However, you have to remember that the frequency and the intensity starts going down usually about third or fourth day, and it tends to come down to a febrile status by around fourth or fifth, or at the most the sixth day latest. That is a typical course of fever. In contrast, the respiratory symptoms may be a little mild in the first day or two, but they tend to peak at about third, fourth day. And you can see the duration of the respiratory symptoms. So the respiratory symptoms may get prolonged for almost 2 weeks. And of course, you have to remember that the respiratory symptoms go on improving. It is not that they are at a very severe level and remain at the severe level for a longer time. They are at their peak around 3 to 5 days and then start decreasing, but may linger on up to even 2 weeks. So if any patient is behaving or not behaving according to this typical graph of the symptoms, then you need to be a little cautious that whether they are having any severe or complicated viral infection, or they are having any secondary infection, or whether you need to investigate this child or so on. But if they're following this typical course, then it is just a matter of supportive treatment.
Right, very good. I'm glad that you brought out this point because many times, as you said, if the fever doesn't go down or if there are some other organisms like say bacterial infections, then one has to be very, very careful. Sometimes, it's possible that, we have to start either an antiviral or an antibacterial agent in case if the child is not a typical case of viral uncomplicated URI. Okay. So now this brings to an important question as to what are the key clinical red flags? What are the symptoms and the signs which suggest that the disease is severe or going into complications?
So a couple of things we need to remember when we are dealing with these common children, that picking up those children who are likely to get complicated is the crux. So you have to remember about the extremes of age. So very young infant, young perinatal or just post-neonatal, you need to be more cautious in dealing with these children. Similarly, a child, as we discuss about the typical course of uncomplicated viral infection, so very prolonged high-grade fever, say even day 4, day 5, it is persisting, then that is something we should be a little, definitely a little worrying for us. Again, a child who has become severely prostrated, persistent vomiting, persistent lethargy, not active in. So in viral infections, we expect the child to be active in the interfebrile phase. So we get a child who is having bouts of fever, and even in the interfebrile phase is preferring to sleep, not active, not having a good intake, then that is something we should alarm us. Again, a child who is starting to improve and then again worsening after say 1 or 2 days gap. Again, that is something which we need to be aware of, whether this child is developing some complications. A child presenting with respiratory signs of respiratory distress, for example, very highly increased work of breathing, nasal flaring, or severe intercostal and subcostal retractions, and so on. All these things should alarm us that we are dealing with a severe disease or maybe a complication of a simple infection.
Right, very good. So it's very important that our colleagues are aware that if the child has poor feeding or lethargy, tachypnea, that is increase in the respiratory rate, or chest retractions or grunting, so that during the night time in Marathi, what we call it as kanna, the child will do some sounds like during the sleep. So if you ask the parents, they will tell that Ratri झोपेमध्ये कंटो, okay? And then the child in case has hypoxia or cyanosis. After COVID, many parents have these pulse oximeters. So maybe in case if they call you sometime, you can always ask the educated parents to check the oxygen saturation. If the fever is persistently high, that's also something which is not good. And then particularly young children, maybe intermittently can have apnea, which is also a red flag. And of course, children who do not have adequate fluids can get dehydrated. So all these they indicate need for urgent evaluation or hospitalization. And it's better that if parents, they call you, because many parents are, having the tendency just to call the doctors. Sir, there is only cold and cough, suggest some medication. So ask these things even on telephone, so that you can ask them to come to the casualty or to the emergency room. So now let us see, this case has progressed and the child has improved for a week or so, and then again the child developed high fever with thick mucopurulent nasal discharge. Dr. Sanjay, what do you think? What is going on in this particular child?
So as we were just discussing about the complications of a viral infection, so sometimes as we were saying that the viral infection tends to improve like a typical viral, but then after a gap of wellness, the child again deteriorates. And especially with these thick mucopurulent secretions and some added signs if they are present, for example, facial pain or tenderness or a severe headache or a post-nasal drip, you should always suspect in terms of complications like an acute bacterial sinusitis. So sinusitis again can be viral and bacterial, but in this situation, with a initial improvement and then worsening, you should think in terms of bacterial infections. So, what are the different presentation of bacterial infections? Is could be just nasal congestion or rhinorrhea of more than 10 days. We said that the infection in a viral the symptoms tend to improve by about 10-12 days. Improve. So here the symptoms are not improving; they are persistently the same severity for more than 10 days, or there is very high grade fever for 3 to 4 days with purulent rhinorrhea, or as in this case, there is return of symptoms after initial resolutions with new or recurrent fever, increasing rhinorrhea, or increasing cough, and especially along with headache and maybe facial pain. That would definitely suggest a possibility of acute bacterial sinusitis.
Sure.
And the bugs we know which are involved in bacterial sinusitis, they are most of the viral infections which are bacterial tend to have these three names cropping up everywhere. So Streptococcus pneumoniae remains the commonest even for sinusitis. H. influenzae, non-typeable, not the type B. This is the non-typeable H. influenzae, and Moraxella catarrhalis. These are the common bugs which are involved in acute bacterial sinusitis.
Sure. Of course, everybody knows that bacterial infections in the upper respiratory tract usually are treated by antibiotics like amoxicillin, and the resistant cases with amoxiclav. Let us go to the next case. And this is a 6-year-old boy with fever, throat pain, and vomiting. And on examination has swollen red tonsils and the lymph nodes are tender. So, Dr. Sanjay, what do you think is the likely diagnosis?
So in this case, with the swollen red tonsils with a tender jugulodigastric lymph nodes, I would definitely think in terms of acute tonsillopharyngitis. We have to remember that in the young age, 4, 5, 6, 7 years, the tonsils normally tend to be a little big because that is the growth phase of the lymphoid tissue. So the redness and the tender lymph nodes are what is going to add up in making our diagnosis.
Sure. There are differences in the viral and the bacterial throat infections, and one should be aware that the viral respiratory infections, particularly viral infections, which we just discussed, have associated conjunctivitis, coryza, cough, diarrhea, hoarseness of voice, and discrete ulcerative stomatitis. And there could be viral exanthem, there could be rash on the body. That means in the same child, more than one system will be involved. For example, the respiratory, the GI, as well as things like viral rash. While bacterial throat infections, this is Streptococcus pyogenes. It is different from Streptococcus pneumoniae, which Dr. Sanjay just said. They are the ones which are responsible for acute tonsillopharyngitis. Though remember that tonsillopharyngitis in almost 70% cases again is viral, and in 30% cases it is bacterial. And the most common bacterium is Streptococcus pyogenes. So there is sudden onset of sore throat, and this is very common in age group of 5 to 15 years. This is the school going age, and the child has fever, headache, nausea, vomiting, abdominal pain. tonsillopharyngeal inflammation, and there are exudates on the tonsillar area, and there are petechiae on the palate, and there could be tender cervical nodes, anterior cervical nodes, and sometimes there could be a scarletiniform rash. It's a rash, and sometimes streptococci are known to produce what is called a scarlet fever, where there is rash on the body. If possible, we will show some picture. Now, Dr. Sanjay, there is some scoring system which has been always discussed about some of these viral bacterial infections and how to differentiate. So, will you like to elaborate a bit on that?
Yes, sir. So the important thing is, when do we need to really think in terms of bacterial and think of starting antibiotics? Because as sir has said, almost 70% still tend to be viral infections causing acute tonsillopharyngitis. So these are the Mackey's decision rules, which can be used even in our OPD to decide whether we need to think more in terms of bacterial and do the requisite tests. So what do they consist of? So a temperature more than 38 degrees Celsius is given 1 point. Similarly, absence of cough is given 1 point. Tender cervical adenopathy is 1 point. And tonsillar swellings or exudates are given 1 point. The last point is age dependent. So in the age group, which is the typical age group, 3 to 14 years, if the patient belongs to this age group, he is given 1 point, because the chances of having a bacterial infection of the tonsils is higher at this age. 15 to 44 years, it is 0 point is given, and an older or elderly person, a -1 score is given. So that indicates that a elderly person is very highly unlikely to have a bacterial strep, let us say, tonsillitis. So you add up the score, and if the score is say 4, then the chance is around 38 to 63% that this is because of Streptococcus pyogenes, and you need to decide whether you need to confirm it or start antibiotics. A score of 3, maybe only 1 in 3 patients is likely to have the bacterial infection. And a score of 2 or less, you can just decide that this is less likely to be a bacterial infection, and think in terms of treating it like a viral tonsillopharyngitis.
Right. And then, of course, as we said earlier, bacterial throat infections are treated usually with amoxicillin. But remember, you have to give it for 10 days and not for 3 or 5 days. Now, there are some pictures which we would like the audience to try and answer as to what it is. And then, Dr. Sanjay, you can just explain as to what is the difference in the two pictures, and then we will disclose the diagnosis. So could you just tell a bit about these two photographs?
Yes, so the first one which you projected, the one on the left, it has, you can see lesions at the angle of mouth just around the lips. And there are some lesions on the lip as well as on the anterior part of the palate. So these lesions are very typical of stomatitis caused by herpes virus. So HSV is the common organism involved in this. So remember, the anterior part of the mouth is involved in this with ulcerative lesions, as well as the lips and the angle of mouth are commonly involved. So perioral and anterior part of the mouth. In contrast to that, in the second image on the right side, you can see ulcerative lesions on the posterior part of the palate. And this picture may not be very clearly showing, but they are commonly also seen in the tonsillar pillars, on the anterior tonsillar pillars. And these are commonly because of the Coxsackie or the enteroviruses, which we discussed initially. And the terminology used to describe these lesions or this illness is called as herpangina. So both basically are viral infections. The presentation may be severe, especially in herpangina, with the child not able to swallow and drooling saliva and irritable because of the severe pain during swallowing, but requires only symptomatic treatment, no role of antibiotics.
Sure. Now, in the routine pediatric practice, it's possible that our colleagues find it very difficult to differentiate the viruses, but to understand whether it is influenza or whether it is RSV, or if there's some bearing on the treatment, when should we test for the viral etiology? Like, what is your opinion?
So, most of the cases which we see in our outpatient practice do not require any viral testing for confirmation of their etiology. Then who would you like to test? Because the tests nowadays are available, and they're quite good tests. PCR-based tests, microarray are available. And the ideal situation where you would want to use this test is in a severe viral infection, which is not behaving like a typical uncomplicated viral respiratory infection, or maybe a child who is having a comorbidity. For example, he has some other, for example, he's a heart disease with a respiratory infection which is not behaving typically, or is a malnourished child. or the infection is very severe or requiring him to be admitted. So a child who is requiring admission, I would probably think in terms of doing a testing for viral etiology with the PCR based test in the form of a nasopharyngeal and a oropharyngeal swab.
Right. So, as our colleague can understand, basically, whenever the results of the test are likely to change the management, for example, using antivirals for influenza, or as Dr. Sanjay said, when there is a severe disease or admission in the ICU, or there are some situations which are called as high risk situations where we need to diagnose what is the type of virus, or sometimes for the control of the outbreak or cohorting in the hospitals, we may require some of these tests, and that's very important that we understand. And as we are discussing on these tests, Dr. Sanjay, you could just tell us as to how one should interpret the positive viral PCR result. That means if the test comes positive for H1N1 or for H3N2, or it doesn't come positive. So, what are the various aspects of the interpretation of these tests?
So one thing we have to remember is when we are sending the test, we have to be aware of what is the pre-test probability of the test coming positive and what we are suspecting. That needs to be kept in mind. So the clinical picture has to be supportive of the result we are seeing. If it is not matching, then you have to take it with a pinch of salt. Also, you have to take some precautions when taking the test. You have to remember that the nasopharyngeal, oropharyngeal swabs need to be taken properly, transported immediately, and they are not representative of the lower respiratory flora. So they can be only used to find out the etiology for the upper respiratory infections. For a lower respiratory infection, it would be better to look at the sputum or maybe a ball or something of that sort to decide the etiology and interpret the reports of a viral PCR. And having said that, looking at the clinical picture, the epidemiological situation, one has to interpret the positive viral test results. For example, of a child who is presenting with a severe type of respiratory infection, if you do a nasopharyngeal swab and get say something like a rhinovirus, we would take it with a pinch of salt because it is unlikely to be a rhinovirus presenting with a severe respiratory infection, severe pneumonia, for example, or a very bad upper respiratory infection causing severe prostration. So that is what we should remember when we advise these investigations and then when we interpret them.
Sure. So maybe I would say that a positive PCR indicates that the virus is detected and not always this virus is the cause of that
Positive.
condition. And co-infections, as Dr. Sanjay said, are very common. And the viral shedding, it may persist for some days. And then clinical correlation is essential. And the treatment should not be based on PCR alone. So with that, we come to one additional case. He's a 3-year-old child who visits the emergency room at 2 o'clock in the morning with history of sudden onset of breathing difficulty, preceded by history of mild cold and fever. And this child is restless but comforted by the parents. And there is an audible stridor, that's an inspiratory sound, at rest, stridor at rest. That means even when the child is not crying, or not, involved in any activity, worsening while crying, and there is minimal intercostal retraction with the heart rate of 120, respiratory rate of 26, and saturation at 92%. So with this, the diagnosis appears to be croup, that is laryngotracheobronchitis of moderate degree. So having said that, Dr. Sanjay, would you just like to elaborate a bit about this condition called croup with the help of this particular case?
Right. So this is the typical infection in the younger age group, say first 1, 2, or 3 years. It presents with a stridor, which is the most prominent and worrying symptoms for the parents, and a typical harsh or a barking type of cough. So the cough you cannot miss once you hear it. It is a very harsh cough. Inspiratory stridor is characteristic, and the child may have a hoarse voice as well. Sometimes it may give rise to respiratory distress, especially in the severe stridor. A mild or a moderate stridor may not give rise to that much of a respiratory distress, but a severe stridor, you may get respiratory distress in some patients.
Yes. You can
Etiology,
also,
yes, sir. The
yeah.
etiology commonly, as we discussed initially as well, para-influenza accounts for almost 3 out of every 4 patients coming with croup. So it is by and large the commonest virus which is involved in causation of croup. Having said that, influenza is also involved sometimes, and it can present as croup, And the other viruses like the adenovirus or the respiratory syncytial virus can also sometimes present with a similar presentation. Rarely we get bacterial infections like diphtheria, which can cause upper airway compromise, and sometimes even mycoplasma presenting with this stridor like presentation and behaving like a typical patient of croup.
Right. So it's important that we remember that this particular triad of barking cough and stridor and hoarseness of voice, as the larynx is involved, which is the voice box, the voice changes. And as the narrowing is present at the laryngeal level, when the child breathes in or takes the air in, that is inspiratory phase, there is a stridor. And again, as this larynx is involved, there is barking type of cough, and one can easily make out such conditions even when the child is sitting in the OPD. And of course, I always say that louder the voice of this cough or the noise that the cough makes, lesser you need to worry because these are viral infections. However, there are conditions which are fortunately not very common in our country, like epiglottitis, where H. influenzae, the bacterium, is the one which causes this condition, which leads to high fever. And as the child is unable to swallow the saliva, the child drools out, and this child appears obviously toxic. But for some reason or the other, this is not very common in our country, and one has to be aware of this. Of course, drooling of saliva in respiratory infections does occur. Even the earlier conditions where we saw that there are some ulcers like herpangina, where child simply is unable to swallow or he is afraid of swallowing because it gives pain. Sometimes it rules out a lot. So one has to be aware of some of these things. And then, based on these features like the stridor and chest retractions and cyanosis and the heart rate, respiratory rate, and the mental status, the condition called croup has been divided into mild, moderate, and severe. And Dr. Sanjay, will you elaborate a bit about the investigations in these children?
So by and large, it is a clinical diagnosis with the typical history with the triad that you have already mentioned, sir. So barking cough, hoarseness of voice, and inspiratory stridor. If it comes, you need not do any investigations at all. However, there are situations when we discuss about moderate and severe croup. So the croup is worsening, the child is developing a respiratory distress, or is not responding to our standard treatment, which we'll see. Then we need to think of doing some investigations. Sometimes there are things which behave like croup, but they are not responding and they are croup mimics. So here we need to do the investigations. And the investigation of choice, as we all have learned in our undergraduate days as well, is the X-ray neck, where you get the steeple sign, which is positive, which is showing the very narrow area of the airway around the vocal cords. So that is the steeple sign which we see on the X-ray of the neck.
Right. And of course, maybe our colleagues are, in case if they are not very confident about these conditions, it is always better to involve an ENT surgeon or a senior colleague so that they are a part of the management team, because many times the parents are worried. And in case if you are not very confident, please see that you involve some senior pediatricians or ID experts in the management of such children. Dr. Sanjay, you can just briefly tell us the treatment of this condition.
So the more the child is irritated, the more the stridor increases, and you have to ensure that the child is in a position of comfort. Don't make the child unnecessarily lie down in the hospital bed. It is better that the child is in the lap of the mother. Most of the times, if it is a mild croup, you need not do anything. You may just observe the child for 4 hours, or 6 hours, maybe in the emergency room, and then just send the child home if it is not worsening and it is improving. However, if it's a moderate or severe croup, we would definitely like to give the drug of choice, which is the corticosteroids. So the steroids in the form of either oral or intramuscular, and nowadays even nebulized steroids are have been recommended in some guidelines for the treatment of moderate to severe croup. Sometimes you need to repeat, especially if it's a nebulized steroids, you need to repeat the doses at intervals to ensure that the treatment is complete, and then think of discharging. Other additional things like nebulized adrenaline can be used if the symptoms are not sufficiently responding to our steroids, because all said and done, the steroids do take some time to work, and the adrenaline may help in the intervening period. And it can be repeated if the child is improving and showing improvement with adrenaline, you can repeat it as well. After
Sure.
this treatment, if the child is asymptomatic for a few hours, you can observe and again send back the child home and call them for follow-up.
Right. Of course, this is the dosage of steroids and adrenaline, and one should remember that the dosages are to be strictly followed. Now, Dr. Sanjay, what do you think as to the reason as to viral respiratory infections, which we discussed till now, they present so differently in children as compared to adults? What do you think? What is the reason?
So the most important reason, of course, is going to be the level of immunity which the children have developed against these various viruses. So when the child is going to the play group or the creche or the school, he is getting exposed to so many different viruses at multiple times, and hence they are still in the phase of developing the immune response to these various viruses, and as a result, they can present in varying amounts of severity. Sometimes they come with a little atypical presentations. For example, a child of influenza may come with a gastrointestinal presentation as well because of the age-related issues. And hence, you have to be a little cautious when you're dealing with children, when you're thinking in terms of simple, uncomplicated viral infection, or the infection is getting complicated.
Sure. So, as you have rightly said, the children in general have immaturity of the immune system, and the airway caliber in children is also very small. And there are certain factors like prematurity or nutrition or some associated morbidities, which we call as comorbidities. So, the point is that the same virus can cause mild upper respiratory infection in one child and severe lower respiratory infection in others. So that is the reason why viral respiratory infections present so differently in children. Now we'll come to the case number 4, which is a 7-month baby boy brought with complaints of increased respiratory movements and difficulty in feeding since one day. There is a history of runny nose preceding and fever for 1 to 2 days. And clinically, this child has tachypnea, that is increase in the respiratory rate, retractions, and wheezing. So this has been diagnosed as a case of bronchiolitis, which is a pulmonary infection of the young children under the age of 1 year, characterized by wheezing. It starts as cough and coryza, leading to respiratory distress in 2 to 5 days. It presents with fever and tachypnea, wheezing, prolonged expiration, and one has to watch for apnea, dehydration, and respiratory failure. It is important to note that this is again a viral respiratory infection, and the only two things which help management are maintaining the hydration and preventing hypoxia. Usually, right from our residency days, we have been told that antibiotics, bronchodilators, and steroids are of no use in such conditions. Some of these children in future, they may rather turn out to be the ones with hyperactive airway, and maybe the ones in the beginning of their asthma career, you can say. But then many times it's the individual decision and response to bronchodilators which usually decides some of these areas. So, Dr. Sanjay, will you like to elaborate a bit about the causative organisms related to this condition in brief?
Yes, and the notorious RSV is the most common causative organism of bronchiolitis. But some other viruses like human metapneumovirus, sometimes rarely rhinovirus and adenovirus can also present with a bronchiolitis-like picture. We have seen children presenting with croup in an infection with influenza. So influenza does present like croup, and occasionally parainfluenza can also present like like a bronchiolitis.
Sure. And you can also mention a few points about management and the
So if it's
admission
a
criteria.
mild version of bronchiolitis, then you can as well send a patient home, but keep him on close follow. However, if the saturations are a little less, for example, less than say 91 or 92%, you would prefer to admit the patient. If you do a blood gas analysis, then the PaO2 of less than 70 in room air is something which should definitely provoke admission. And then children with some underlying disease like underlying cardiac disease or a pulmonary disease or some with high risk factors for apnea, they definitely need to be admitted and kept under supervision and sometimes even admitted in the ICU as well. Treatment, as sir has mentioned, is mainly supportive. So oxygen is all that has been shown to definitely have a role, and as well as good hydration definitely has a role. Nebulous bronchodilators, we know it's a controversial thing. If you can give a trial and they are showing a response, then you may continue. Otherwise, you need not. Hypertonic saline does have a role in treatment of bronchiolitis, And role of nebulized adrenaline is still open to like controversy and may not be commonly advocated.
Right, that's very important. So just remember that there are some core principles of managing viral respiratory infections in children, like supportive care that we have said in the form of hydration or medicines like paracetamol or oxygen whenever needed, avoiding unnecessary medications, monitoring for complications, and educating the parents about the course of the illness. And most viral respiratory infections, as I have told you, and Dr. Sanjay has emphasized, they are self-limiting. Now, we have already discussed a few points about reducing the inappropriate antibiotic use in the viral respiratory infections. And we will just discuss a few points about influenza. And Dr. Sanjay, how does influenza differ clinically from other viral respiratory infections in children?
Having seen a lot of influenza cases in the last few months, we know that influenza often comes in like sort of local epidemics. So, a lot of children getting affected at the same time in the schools, and then the carrying infection home as well. And they have different type of presentation in different children, as you already mentioned. So many of the children tend to be having very mild symptoms and recovering spontaneously, but they have a potential of getting worse as well, and some children do progress to even pneumonias which require ICU admission. And we have seen in previous decade of, regarding the pandemic with the H1N1 pandemic flu strain, that they may progress to pneumonia, ARDS, and so on. Also, multi-system infection or presentation is common. So the child may also have generalized malaise, then gastrointestinal symptoms, and occasionally we have seen children getting complicated with involvement of the heart, that is the myocarditis, and some CNS presentations in the form of, say, encephalopathy or encephalitis like presentation has also been seen. So though by and large a common viral infection, we have to keep our guards, our awareness regarding the potential of complication of this infection.
Sure. So that's very important that our colleagues are able to identify likely case of influenza. All these cases which come to us with cold, cough, and fever, they have a broad group of what are called as influenza-like illnesses. But influenza is, I always say, is a father of all those influenza-like illnesses. And a child will come with sudden onset of very high fever. And typically, child will have headache, an older child will have, weakness and pain in the muscles to such an extent that sometimes the father has to lift up an older child, even 8 or 9 or 10 year old. That is all because of this severe myalgia and malaise. These children usually have a dry type of cough to begin with, and children also may have the gastrointestinal symptoms because this is a viral illness, and some of these children can have vomiting and diarrhea. So do not be misled by that vomiting and diarrhea. They may be having influenza, and as Dr. Sanjay has said, they are more prone for complications. So one has to find out in all the gamut of the viral respiratory infections that this is not influenza. And then, Dr. Sanjay, I'm sure you would like to tell our colleagues as to who are the children who are at a high risk of severe influenza and the ones who need to be rather noted down properly.
Yes, so as we discussed, those are the extremes of age. So young infants, especially say less than 1 or 2 years of age, we need to be cautious because they can progress very rapidly and end up in severe influenza. At the same time, children with some comorbidities, for example, those with a respiratory comorbidity, like say a child with asthma on inhaled corticosteroids, or a child with a congenital heart disease, one with say a nephrotic syndrome who is on steroids occasionally or intermittently, or one with who is maybe having some other, it's like something like obesity, which we see so commonly. All the children tend to be at a higher risk of a severe influenza, and we need to be careful while dealing with them and maybe start the antiviral therapy which is available for influenza a little bit early.
Sure. So this is something which is very important. And then one should always know as to when one should give antiviral therapy for influenza, because oseltamivir is one of the medications which is ideally given within 48 hours of the onset of symptoms, and it can be given at any time in the hospitalized or the high risk children that we just saw. And oseltamivir remains the most commonly used antiviral in pediatric practice. And one should remember that whenever you start oseltamivir early, the severity of the illness is reduced. The chances that the child needs to be hospitalized are reduced, and the mortality also reduces. There has been a lot of experience with this antiviral during the pandemic of 2009, which almost all of us have witnessed, and one has to be very, very careful. Why this point is important is because many times when we treat any child with viral respiratory infection, one fails to realize whether it is viral or bacterial at the first count. In case if you find that there is some infection, then one tends to start with amoxicillin. And knowing the fact that 80 to 90% children have viral upper respiratory infections, for unknown reasons, still now I have not understood as to why pediatricians, even when they make a mistake of starting amoxicillin when viral infections are so common. So if there is an atmosphere around where there is a lot of influenza going on, your other children coming to the OPD, some of them have tested positive for either H1N1 or H3N2, it is prudent and wise to see whether this child has symptoms and signs suggestive of influenza and put him on oseltamivir. Continuous updation of the knowledge is very, very important for all this. Now, Dr. Sanjay, what all preventive strategies are most effective in reducing the viral respiratory infections in children, as per your opinion?
So again, a lot of things come into play here. So the parents should remember if their child has a respiratory viral infection, they should not send that child to the school or the daycare because he's going to spread the infection and cause more infections. For the personal, that is a child itself, a good nutrition, a good exercise in open air is definitely going to be helpful in building up the immune system of the child and preventing severe types of viral infection. Of course, we all know vaccination plays a big role, and we have a vaccine available against especially the influenza virus, which does have an important role in preventing this repeated viral respiratory infections in children. So all in all, good nutrition, diet and vaccination is what is going to help the children to take care against viral respiratory infections.
Sure. So it's very important that we ourselves also follow certain etiquettes, particularly the hand hygiene. Then many times children who come to our OPDs, they directly cough on our faces, and then in case if we do not wear the masks, we are also prone to get influenza and infections of the respiratory system. So wash the hands, keep other persons who are unwell a bit away from you, and also use handkerchief, cough in the elbows, and get yourself vaccinated every year. I always say that happy birthday to you to be said followed by happy birthday to flu, because every year you have to take one shot of flu vaccine. Even measles vaccine in children will reduce the chance of upper respiratory infections, and then you have to avoid the exposure during outbreaks. And breastfeeding, of course, in very small babies definitely is very, very protective for children. So let us come down to the key messages, which say that most of the viral respiratory infections are benign and self-limiting. That is number one should remember. But clinical vigilance, watching these children, testing rationally when you're required, and use of antivirals judiciously, and following that antibiotic stewardship, not to use antibiotics when not required, and strong preventive strategies, particularly influenza vaccination and those precautions related to the hand, they are very, very important in improving the outcomes in pediatric practice. With that, I thank you for a patient listening, and thank you, Dr. Nathu, for all those crisp answers. And I hand over the proceedings to Dr. Prashant.
Thank you, sir. Thank you so much. One thing that has amazed me, sir, is MA in Sanskrit and expert in French and I mean, and lovely insights into both bacterial and viral infections. I'm sure the audience has benefited. This is a different type of session. Thanks, Dr. Sanjay Nathu, for throwing light on these infections. Thanks, Sai Shrikar. Thanks, Samriti. And thanks the doctors who took time and attended this session. Thanks all the sales team and marketing team for making this possible. Thanks, Sai Shrikar, for your IT support. Thank you so much, sir. Wish you a very good evening, and we can log off, sir.
Thank you. Good evening.
Thank you, sir.
Thank you.
Thank you.